In 5, 4, 3.
Hello, tonight it's time for another student webinar. We're on number 33 already. Time is going by fast. Well, we had a request that come in that said that they wanted to get a little extra training on coding ICD-10 for injuries. And they specifically said they were struggling with initial, subsequent, and sequela. Now, as you may or may not know, with ICD-10, the seventh character usually is how, with injuries, we're going to let everybody know whether this is an initial, subsequent, or sequela in the visit. I took straight from the guidelines some of the specifics when it comes to coding for injuries that talk about just this, especially subsequent. So we're going to go over that, and hopefully it will alleviate some of your fears or answer some of the questions that you have regarding these three things: initial, subsequent, and sequela when it comes to working with injuries. And again, like I said, I pulled the guidelines straight from, it's the 2019 guidelines. You can get them off of cms.gov if you want. Instead of just bringing over the guidelines and us going through them, I went ahead and kind of separated them out because my brain doesn't work as well when I see things like in a paragraph. I have to have highlights or things to bring my focus in. So I thought I would do that instead of having to see all of the guidelines at once. So these are going to be the guidelines that I thought were pertinent regarding the initial, subsequent, and sequela as it pertains to injuries, because it involves other things. And so you'll just be able to follow along. In some places I've kind of indicated the title, but it's not so much of that. It's not that I want you to be able to locate it in the guidelines, because if you read the guidelines, like we say, at least 3 times before you test, then you're going to be able to find this. So again, it's not necessarily about finding the guideline, as maybe I can take care of some of the gray areas that are involved there for you. So the first thing is we start at the top of the guidelines and we filter through on things that I think would be pertinent, was laterality. There is a specific note that you need to make for yourself regarding coding for laterality with a subsequent encounter. Okay, now we're going to talk about what is initial, what's subsequent, and what's a sequela in just a few minutes. But the key here is laterality is we're talking about something that is right and left, right? Actually, this is my left hand and this is my right hand because everything's probably reversed with the camera for you. So if we have a reason to come in for a visit with an initial encounter, and it's got something that deals with laterality. Let's say I'm trying to think of, we have an injury to both of our hands. Okay, let's say we have a burn to both of our hands. We have a 1st-degree burn on one hand and we have a 2nd-degree burn on the other hand. Okay, now if we are not in the initial treatment anymore and we are into our subsequent visits, right? Now, also, laterality probably isn't going to be involved with burns like that, but we're just using this as an example so you can get through the concept. If we have bilateral burns, on both of our hands, and for the subsequent encounter, so we'll just say 2nd encounter of treatment, one side is no longer exists. So since this was a 1st-degree burn, it's already healed. There's no signs, symptoms, or anything for that burn anymore. It's no longer bilateral, right? Now it's just the left hand that had the second-degree burns that still has, you know, signs and symptoms, and they're still treating. They don't need to treat this hand anymore. It's all healed up. So, but this hand still is going to get treatment. It's checking it and everything. So then we're going to code for just the left hand burn, not the bilateral burn, right? Be careful with that, because when you're looking at subsequent encounters, sometimes the code doesn't follow. The code changes throughout each encounter. You can't just grab the previous code. You've got to go look at the code and make sure it's still applicable. So if you coded for the initial encounter something that had laterality, right? But the laterality, the injury no longer applies to both sides after with the subsequent visit and stuff, then we're going to change to a unilateral code. Now, they gave the example, and it's in your guidelines, of cataract surgery. So let's say you did cataract surgery to each eye in separate encounters, right? So you may have bilateral cataract surgery. They very seldom do cataract surgery on both eyes at the same time. That's really rare. They'll do one eye and then they'll do another one. But in the meantime, one eye will be completely healed, right? So there won't be laterality there. Because one side is completely healed and no longer is getting treatment. Just make sure that when you look at why the reason the person was there for an initial encounter, okay, they come back for a second encounter and there's laterality in the codes, that the codes still need to be defined as bilateral, or if it needs to be switched to a unilateral code, right? And that is going to be on a subsequent encounter. Now I want to talk about pathological fractures and the seventh character. With fractures just in general, we're always going to be getting to a seventh character. And you understand that a pathological fracture is a fracture that's caused due to a disease process. And for the most part, these guidelines are the same for pathological fractures as they are for traumatic fractures. Just note, mind you, that we're not talking about pathological fractures as they differ from traumatic fractures. No, we're talking about the seventh character. Okay, so again, as we walk through the guidelines from the top to the end of the guidelines, this is what the pathological fractures came up first. So that's why we're bringing that up. So whenever we look at a pathological fracture, right, the initial encounter or active treatment for the fracture will be an A. The seventh character is going to be an A. However, we have to pay attention, because this gets really confusing for new coders. And even if you've been coding for a while, you have to sit back and think for a second. Now, wait a minute, are we actively treating, or are we in the healing process? Where are we at, in this process? So if we're getting active treatment, so we're manipulating the bone, we're doing something to the fracture itself, right? Then it's going to be an A. However, think to yourself, we're following the fracture, not the provider, okay? So if the patient is being seen by a new or a different provider, okay, for the pathological fracture, and it's the patient still undergoing active treatment, okay, it doesn't matter if it's the first time for the visit, right? The key is this active treatment? Now, with fractures, some examples you're going to see of this would be a patient who came into the ER and they want them the next time, like in the morning, to go and see the orthopedist, and the orthopedist decides to manipulate the fracture or and maybe cast the fracture, okay? Because a lot of times they'll just put a temporary casting splint to get them stabilized, so then they can go to a specialty, the pathological or the orthopedist. Okay, we're still in active treatment for the fracture. It's a different provider, and it's a different time in the visit. So they've had initial treatment in the ER, and now they're going to an orthopedist. We're still, though, in active treatment. It follows the fracture and the treatment of the fracture, not how many times they've been seen and not who they're being seen by. Okay, they'll give you questions like this for that 7th character to make sure you understand it. Most of the time, though, with a pathological fracture, what they're testing you on is, do you understand the difference between a traumatic fracture and a pathological fracture, and how you code that differently? Okay, so when you see anything that says pathological, that's probably the concept that they're wanting to make sure that you understand. Just remember that when you're dealing with fractures, that it is based on the fracture treatment, not how many visits you're in to the treatment or who the provider is, if it's a new provider or not. Okay, very, very important. Now, the 7th character of D is going to be subsequent. Now, this is really hard when you're looking at fractures. What constitutes active treatment and the healing or recovery phase? Because the initial treatment is easy, right? The first time the patient's seen for a fracture, we know it's an A, but what is the determining factor that says now we're in the healing phase? And then it would be classified as a D and not an A. Once you have encounters that are working through the healing or recovery phase, you're going to stay with the 7th character as a D on throughout the healing process itself, until the provider states that it's completely healed, right? And then you may have something like if you had to have a history of, or then you're going to switch over if there is a late effect, a sequela, maybe, that needs to be mentioned. Otherwise, once the fracture is healed, you were done, right? So let's talk about what constitutes an active treatment versus healing recovery phase. If a patient is, let me see if I gave an example of this in the next one. Well, I said, okay, yeah, let me go back, because I've got some examples and I got a couple films to show you. I don't mean films, we don't say that anymore. X-rays, to the example. When the patient first comes in and they determine that it's a pathological fracture. Now, a pathological fracture is going to use different treatment maybe than a traumatic fracture, because remember, we have a disease process going on. So a pathological fracture includes that disease process. Let's say our patient has severe osteoporosis and they fall and have a Colles fracture, which is very common with elderly people, where they fall and they catch themselves with that wrist, and it's a special type of fracture in the wrist on the ulna and radius. I can't remember if it's on the ulna or radius at the time, but go look it up. It's a Colles fracture. And so because the patient has osteoporosis, they get a diagnosis of pathological fracture, and the initial treatment is going to be in the ER, where they take the X-ray, they determine that, that's what it is. They go to the orthopedist, and the orthopedist says, yes, this is a pathological fracture and that it is a Colles fracture. Okay, so we're still saying at a higher specificity because fracturing the wrist isn't always a Colles fracture. A Colles fracture is something very, very specific. It's a very specific type of break because it's so common, and it's usually common with elderly people. So if a child were to fall and catch themselves with their wrist and actually break a bone in that area, it probably isn't going to be a Colles fracture. It'll be a different type. Well, actually, let's back up. Let's say we go into the ER and we know it's a pathological fracture because the patient has osteoporosis and the provider in the ER says, yeah, it's a pathological fracture. And he said, yes, it's a fracture of the wrist there, of the tibia or the ulna and the radius. But he says, I want you to go to the orthopedist, and they go to get a higher specificity. So the orthopedist looks at the x-ray and he says, you know what? We need to have an MRI of this. And this is so swollen, we really can't get a good view. The x-ray isn't as good as a view as I would like to see. And so we're going to wait a week and we're going to let the swelling go down and we're going to take another x-ray, but I think we need to go ahead and get an MRI. Because if it's a specific type of fracture that I think it is, it's a different treatment. I may have to put a pin in versus something else. Okay, so is it still a healing or recovery phase? No, it's not. So we're still in the initial active treatment because we're getting an MRI, and then we're going to have a procedure done on that wrist probably to put pins in. We're still in active treatment. The treatment isn't done, and we're not just waiting for the patient to heal. You see what I mean? And so they do the MRI a week later and they say, oh yes, this is definitely a Colles fracture. And the protocol for a Colles fracture with a patient that has osteoporosis is going to be, and then they decide to go in and do surgery and put pins in. Okay, so they put the pins in, the patient is discharged, and they go home and they follow up a week later, and the doctor says, yeah, everything's looking good, the pins look good, and so they are now in the healing or recovery phase, right? He says, okay, now I don't need you to come back for 4 weeks, and then we're going to check it then. Okay, still healing and recovery phase. But that initial, the A, would be there when they have that that MRI, because it's following the treatment and the fracture, not the provider or how many times they've been seen. Just a note that sometimes you can have complications that are involved. Now, this is also noted in traumatic fractures, which we'll kind of highlight on. But if you have complications with a surgical treatment, then during that healing or recovery phase, it should be quoted with complication codes. Okay, so our patient went in, they had the x-ray, they had the pins in, and then a week later, and they're supposed to be in the recovery phase, all of a sudden their wrist swells up and their fingers are starting to turn blue. They go in and they look and they see that, it's really, really swollen. They take off the cast and say, oh, we've got an infection. This is a complication of the, which changes the process. So we have a question that came in from Karen. It says, how about if they come in the ER and if they come back a couple days later since the cast is uncomfortable, is this still active? Well, if they're not sent off for another doctor, meaning no other treatment is being done, and the cast is uncomfortable, then we need to see, why is the cast uncomfortable? Is it a complication to the fracture? Or is it just that they didn't get enough padding in there and the wrist is still swollen? Or, what's the process that's happening? Maybe it's a complication, not of a surgical treatment, but it's a complication. Okay, then absolutely it could be active treatment, but most of the time it's not. if they have to take the cast off and reapply the cast, then that is it's determined by the provider. Is this still, just routine healing? Because that is appropriate for a cast to be taken off and another cast to be put on for various reasons, especially if they put pins and stuff. Sometimes they'll cut out a spot where the pins are still exposed. It just depends. Nowadays, they don't cast as much as they used to because they've got all those fancy braces and stuff that you can have put on. And they consider your lifestyle, if you're old enough to be able to take care of it, or if you're going to be a child up moving around all the time, yeah, they may cast it. So again, active treatment. If is it active treatment to the fracture, or is it just the cast is just needs to be redone? Okay, it follows the fracture. Are we in the normal healing process right now phase? Right. So again, you'd want to be able to read the whole note. Now, if all of a sudden, like I said, the wrist is swelling and there's a problem, then we can go back to active treatment, right? But again, if it's just something that was a complication of the cast, probably not. And remember, we have to think about the billing process. The cast itself isn't, you don't get paid extra for that per se, right? That's part of the payment you get for treating a fracture, standard fracture. So again, that's why we have to say, hey, is there a problem with the fracture, or is it just the cast? And that's why we're redoing the cast. Now let's talk about codes S00 through T88. These are codes that are often found with injuries, but it's more than that. I always remember the S and T. I think of fractures with S and T, because if your bone is shaped like an S, it's definitely a fracture, right? Or you were T-boned, then you're going to have an injury. So it's chapter 19, but I don't think of my manual in chapters. I think of it as the first character of the code. So, but often they'll say in chapter 19, which is S through T codes. You're always going to use the seventh character if it's applicable, but there are some exceptions with fractures because there's so many other things that we tell in fractures. Now, we're not talking about pathological fractures. We're talking about traumatic fractures, because they'll have subsequent for malunion or non-union and all this other stuff. Okay, so those seventh characters could be different, but for the most part, when we're looking at these S&T codes, we have our initial encounter, we have our subsequent encounter, and our sequela. Okay, and again, initial encounter is why is the person being seen. Subsequent encounter, right? That the additional visits, and the sequela, late effects. Note, though, that the guidelines state, and it's not set up like this. This is all set up in a paragraph, but I divided it up like this so that our brains could kind of grab the pertinent stuff. So if you've got a patient that's seen by a different or a new provider, okay, it's based on whether it's undergoing still active treatment and not whether it's the first time. So again, they're just reiterating, just like we talked about, that for pathological fractures, this treatment criteria, active treatment or healing, and it doesn't matter if it's a new provider or not. Okay. Complication codes can still be applicable in our S&T codes. So I went ahead and put on here the example that they give in your manual. So they give the example of T84.50. X is just placement, because we need more information to be able to place that in an A. So if we have an infection and inflammatory reaction due to unspecified internal joint prosthesis, so they've replaced a joint. Initial encounter, that means that we've got active treatment for the infection, okay, even though, and that's very pertinent, that's why I highlighted that, the condition relates to the prosthetic device, and it could be an implant, a graft, and that was placed on a previous encounter. Because what's going on? It's the infection that we're following, right? We're not following putting the prosthetic in, or, no, that was done before. We have a new problem. It's an infection or some type of inflammation, ultimately a new code. So this is an initial encounter. We're starting over with a new problem. And so it's an initial encounter again. So we probably had an initial encounter before, right? Because we had whatever, they replaced a joint, okay? And they had their initial encounter, and we were into the healing process and stuff, but now we have an infection or an inflammation, okay? And it's due to the prosthetic. So we're back to an initial encounter, because that's the treatment, not the whatever was the causal reason to replace the joint. Jennifer, who is one of our SMEs and instructors, and also happens to work for an orthopedist, she added a comment, which is really good. She says, sounds like routine healing. A lot of times the swelling goes down and the cast can become uncomfortable or too loose, right? So again, so if it's just all about the cast, this is really routine healing. It's not the fracture that we're having to deal with. It's to do, and not really with the treatment, but the device or whatever we're using to treat it with, okay? And casts themselves are kind of a sub category. We don't get paid for that cast. It's just part of the process. We know that if you got a fracture, you're probably getting a cast, so it's all bundled in as to the cost that you're reimbursed. Now, there's exceptions to the rules and stuff, but for the most part. So don't think of it as the cast. Think of it, is there a problem with the fracture itself? Unlike an infection or an inflammation, that's different, right? That's something new that has disrupted the healing process. And it's not the reason that the prosthetic was put in. So let's say the patient had severe arthritis of the knee and degradation of the joint, and so they had their knee replaced, and we're a month in, everything was going fine, and all of a sudden now we have an infection and inflammation of that knee due to the prosthetic. Okay, we're starting the process all over again. It's not due to the arthritis, right? That's not, but it is the prosthetic, and there's an infection, there's a new problem, a new timeline or disease process happening. All right. And it's hard when you're new to separate all of those. So you have to kind of like rein yourself in and think to yourself, okay, what is being treated? Well, the arthritis isn't being treated. The new knee joint isn't being treated. No, it's the infection that's being treated. Okay. Here's the one where I grabbed some pictures. I thought this was pretty cool. So if we have a seventh encounter, I don't know, I always pull femurs. It's the largest bone in the body. I like to do things with femurs. So we have an initial encounter for a torus fracture of the lower end of the right femur, initial encounter for a closed fracture. So that's all the information you need. Think about the description of that code, right? So let's start, instead of at the left with the S, let's start at the A. And let's work it backwards, how the code tells us. So we know this is, you're always going to need to know that it's a closed or open fracture. Right, that's like the first thing that you need to know when you go to do fractures. Okay, then initial encounter, yes. Okay, first time they're being treated. Let's say they come into the ER. Now, where's the fracture located? So in other words, we need to know before we even go to pick the code. The first thing we have to ask ourselves, or we won't be able to pick it in the right area, open or closed. Okay, and we'll know it's initial encounter because they're, you know, like in the ER. What's the location of the fracture? It's the femur. What, we have two femurs, it's the right femur. Okay, so we're backtracking the code. Okay, now with fractures and ICD-10, we can really get to a higher specificity with all of this information. We couldn't do this with ICD-9. We wouldn't have been able to do initial encounter and stuff. So one code tells a story. And I told you that the femur is a really large bone, right? So it's divided up. Where is the fracture located on the femur? Oh, it's the lower end. Very good. So it's distal, away from the midline of the body, right? And you can see this fracture right here in this image is right there at the bottom, because those two bones at the bottom that you're seeing, that's actually right above the knee joint. And so they're that picture is the back of the knee, because you can't see the patella, but or maybe it's the side, I don't know. But there's the tibia and the fibia, okay, and then it just completely broke off the lower end of the fracture of the femur. And on top of that, we can identify what type of a break it is. Well, I picked torus fracture, which is more of like a compound push fracture. So again, that it tells us S is a fracture code. 7.2 is going to get us to the fact that, you know, we've got a fracture of the femur, and then it describes that it's a torus fracture of the femur. Then it tells us that it's a closed fracture, and well, the S7.2 tells us that, and then it's an initial encounter, which ends in an A. Right, so came into the ER, they took these initial views of this fracture, and we know where it's located at. Okay, now let's jump to subsequent. Well, this is what you would maybe see in that, which this is not the same fracture, by the way, although it did come from the same, it's called ortho bullet, which I put it in the resources for you. So it very well could be, but I don't think it is. I just grabbed this one because I knew it was a fracture at the bottom of the femur. So now we have subsequent encounter. Let's backtrack it. Now we don't need to know that it's an open or closed fracture, but we do need to know that it's a fracture with routine healing. So they've already gone in, they put the pins in, everything looks good, and this is like a fracture either right after the procedure, or let's say it's that next week. That's what I'm going to say it is. Okay, so we put the pins in, and it looks like the knee or the bone is stabilized, and then it's right femur, lower end torsion fracture. We got to know all of that stuff, but we're in the healing process. We're not going to do anything to it anymore, right? So the pins are put in. Once the pins are put in and they stabilize that bone, now we're into routine healing. Now let's say we go backtrack like that other code, and we get an infection, right? And it's maybe they got an infection because of you know, they didn't have a sterile environment. I don't know. Okay, then we're starting over with a new condition where it's an inflammation. It's not about the fracture anymore. Now, was it because it's a complication that occurred to the fracture, not the fracture itself? This code, the S72.471, is all about the fracture. And the fracture is now in the routine healing state. We're not actively going to do anything to that fracture now. We're just going to let the body take care of itself. And so therefore it's a D. Z codes, just make sure when you're dealing with S&T codes in this range that you do not use aftercare codes whenever you have injuries or poisonings, when the seventh character, that A and D and stuff like that, identify subsequent care. Now, what does that mean? So the example they're saying, okay, so you have aftercare of an injury, then you're going to do the acute injury code, and then the D for subsequent routine healing. That don't get confused with injuries and poisonings. The term follow-up is going to be thrown around, or aftercare, but we signify that by using the D, saying we're in the routine healing and we're just following up. This is subsequent care. We're just making sure that normal process of checking the aftercare that goes with this type of an injury or a poisoning. Right? There are other things that are applicable for aftercare codes, and they're not going to be in that injury and poisoning. So you encounter an example that I came up with, and there's more than one aftercare code that has to do with neoplasms, malignancy or non-malignancy. So I'm not talking about those, right? Because we're talking about injuries and coding to do with injuries. So don't get that type of aftercare follow-up, because you'll see this verbiage thrown around by the provider, but their verbiage that they're using and their meaning isn't the same that we're using as coders. It doesn't translate the same, and that's our job as a coders, to translate the information and understand the difference in the meaning. So that doesn't mean we're going to an aftercare code or follow-up code. No, this would be more like something Z51.89, encounter for other specified aftercare. Okay, and an example is our patient has to have PT, physical therapy, for gait training because or due to Meniere's disease. And Meniere's disease is something that happens to the ear that has like ringing in the ear, but it also makes you very dizzy, right? And so maybe the person is stumbling or whatever, and I just pick gait training. That, don't knock me if you would say, well, that's not really gait training. I just came up with this at the top of my head. Okay, so it's the thought process I'm trying to get across. So, you know, what the patient's getting physical therapy to learn how to deal with being dizzy all the time, or without knowing what, when it's going to come on. So what do? So the physical therapist is going to say, okay, now if you're in Walmart and all of a sudden you get dizzy, these are the things that you're going to do, right? That's part of physical therapy. Or let's say they're just dizzy all the time. Okay, then this is how you're going to learn to rewalk when you live with this ongoing dizziness. Or maybe you're going to get a cane and walk with a cane so that you can stabilize yourself and lean into that cane, so you have something to hold on to if the Walmart shelf starts spinning on you. Okay, that's different. That's a disease, not an injury or poisoning. Because with injuries and poisonings, we're going to use the D code to show that this is subsequent care. Now, can you have dizziness due to an injury or a poisoning? Yes, but that's not going to be an aftercare code, right? That's something different. All right, just don't want you to get confused when you see those terms, because you will see that in the documentation, and it's your job as a coder. They're going to, a question may slip through like this on the exam, and they're wanting to say, hey, do you understand the term aftercare as it is used in at these S&T codes? Okay, what about a sequela? Now, sequelas are often explained with burns, I think. That's one of the easiest way to explain it. I also think of arthritis. If a person has arthritis in the knee, and so they have a late effect is pain in the knee, or let's say they fractured that femur. Let's go back to the guy, has all those pins and stuff in his knee, and now it's been 5 years, and every time a storm comes through and the barometric pressure changes, he has severe pain in his knee, and it stiffens up and he can't walk. Okay, that's a sequela. That pain is a sequela of the fracture. Okay. So that S code is going to be put, the 7th character of S is going to be put on the injury code. What happened to the person? Okay, well, they had a fracture. They had a torus fracture, right? And we know that it was a late effect, that pain that they're being seen for. So, but scar is one. We used to also use polio a lot, but we've pretty much generationally have kind of obliterated polio. I mean, I don't even think my kids understand what polio is. I know what polio is, and I remember, and I've heard of, and I've met with people and been involved in treatment with people that had polio, but back then they were older, because polio was pretty much eradicated. Not completely, but so that generation, the last of the generations that dealt with polio, have kind of already passed on. And so we don't use that as an example like we used to. Now, but burns make a perfect example. So our patient, if we need to know that this is a sequela to a burn, then how are we going to deal with the codes? Well, why is the patient being seen? If they have a sequela for their burn and it's a scar tissue, one of the places that you're going to see that be a complication would be in the hands, of course, because we know that if you have severe scar tissue of the hand, you're not going to be able to articulate those joints in the phalanges like this, right? Because of the skin. It's not the bones that's the problem. It's the skin. It stiffens and it doesn't have that elasticity that we have. So why is the patient being seen? Because of scar tissue, fibrous skin. That's L90.5. Okay, so that's why they're being seen. Well, what caused all that scar tissue? We need to know. It's a 3rd-degree burn of multiple left fingers, and the nails are included, including the thumb, because you can also do without. It's very, very specific locationally. And it's a late effect. So the burn's not there. We're not treating the burn. There's nothing that we're doing to the burn itself. It's done over. The healing process is, nada. It's out there. However, we have a late effect of the burn, and that is scar tissue. So we don't put a sequela code, the 7th character, on the scar condition, right? That's not the story we're telling. The patient has scar tissue of the skin of the hand, okay? And how did they get it? Due to a burn. Well, what's the details of the burn? Well, they had a 3rd-degree burn, and it was multiple fingers, and the thumb was included, and it's a late effect, no more active treatment of that burn, okay? So that would give us our T23.342S. Now, can they have scar tissue building up and it's still routine healing? Yes, they could, but remember, a sequela is a late effect. What's the result? Okay, so the story we're telling is that no, the healing process is over, and this is what we're dealing with now afterwards. Okay, so the verbiage that you're reading, we have to learn to translate that verbiage. Traumatic fractures, pretty much what we were talking about and highlighted before. We the initial encounter, we can use ABC. There's a lot more 7th characters for traumatic fractures. All you have to do is go look up a traumatic fracture of the femur, and you'll see a whole list of 7th characters. Okay, and what you need to do is think to yourself, the initial encounter should be assigned to the patient, and also, if, because you could get this point tested on, who seeks delayed treatment for a fracture or non-union. Okay, so if you have a patient that comes in and they, this happens a lot with cervical fractures of the neck. Man, they went out on the boat, they hit some wakes, they had a really sore neck, but they just took some ibuprofen and think, oh yeah, I probably got some whiplash or something. And 2 days later, it's really severe. And they go back and they find out, oh, you got a fractured neck. Cervical spine has got a compression fracture. And so again, initial encounter still applies there. External cause codes. We just want to highlight the external cause codes and let you know a little bit about them, because when you have a 7th character for an encounter, most of the time the chapter 20 or those 7th Z codes, as I would call them, they could have a letter that would need to be specified. So they still have the initial encounter, subsequent, and sequela. Okay, and it all applies to, it follows the injury, not the treatment or the time frame. Right. So that being said, what happens when we need to use a sequela external cause codes for subsequent visits? You can use a late effect external cause code for initial treatment, but do not use a late effect for subsequent visits or follow-up care. Okay, now that's because external cause codes usually only get put on initial encounters to begin with. Okay, and that's way out on another guideline. So the examples that they're telling you is this for maybe rehab therapy. That would be a good example. So when there's no late effect of the injury that we can state that there's a sequela to, right? So there's no late effect. You're not going to use an external cause sequela. Okay, I think we're getting close in. Okay, aftercare for injuries. We are also not going to use aftercare, which we kind of already talked about that, right? The verbiage isn't the same. So if you have an injury and you have the acute code, so our patient has a fractured femur, right? And they're not going to have Z codes under aftercare. No, you don't use those. That's not applicable. We're going to be using the code that says that has a D at the end. Okay, so we don't really have aftercares for that. Follow-up, also very confusing. So what constitutes a follow-up? Well, we're just keeping an eye on it. So the keywords: continued surveillance, right? The treatment's completed, but they've been, healed and everything's going fine, and the doctor is just following up. Right now, why would you do that? An example: let's say that was a really the fracture of the femur that we did, that torus fracture of the femur. Let's say that the patient has got some pain in the knee, right? And the doctor is saying, well, let's just do a follow-up. Let's make sure everything's going okay, and so they look, everything's fine. They're just continued surveillance. The knee is healed. The treatments are all done, right? But, and they says, okay, no, this pain in your knee is not related to that, or maybe it is, but then it would be a late effect. But we're just following up to make sure that everything is going well, right? Don't confuse them with aftercare. Okay, follow-up is very specific, but that verbiage, aftercare and follow-up, you'll see that written on the documentation a lot. So subsequent care means we're still in the healing process. If everything's healed up, no other treatment, but the doctor wants to see the patient, then that would be considered a follow-up. And if there's no sequela, no problem, then we're good. You often, when you have follow-up coding, you're going to see things like a history code. Okay, history of a pathological fracture. So the doctor's just following up. How's that knee doing? Let's look at it. Let's make sure that we, since we put all those pins in there, let's just make sure that the bone's integrity is doing good. So again, history of a pathological fracture, and then the patient has osteoporosis would be coded. In those instances, you're going to code, the sequencing of the code is the follow-up. Why is the patient being seen? The patient isn't being seen because of a current fracture. The patient's being seen in follow-up. Now, keep in mind, when I'm going through all this stuff, remember, we are only talking about injury codes. Don't confuse that with other situations that are to do with follow-up on your osteoporosis or follow-up on your diabetes, things like that. Okay, we're specifically talking about injuries and how they're applicable. Whenever you have multiple visits for follow-up code, maybe we have to highlight, why is the patient being seen? Then you can use a Z09 code, and that's encounter for follow-up examination after completed treatment for conditions other than a malignant neoplasm. So there's like 2 other follow-up codes, and they're, for a benign neoplasm or a malignant neoplasm, or we've got to follow up. It's not a cancer, but we just need to follow up. And again, that can be common with injuries, right? Everything's healed up, everything's looking good, but the doctor just wants to double check and make sure everything is before writing it off and saying, okay, you're good to go. I don't need to see you again until your regular appointment for regular treatments and stuff. Now, I wanted to highlight observation to inpatient because this could be applicable to injuries. It's not solely for injuries, but I thought it was kind of important just to give you a heads up. So what happens if you have a patient that is had that fracture, right? And the provider put the pins in and says, okay, we're going to have you in observation, but you should be good to go. Everything, went by the book. I'm not concerned about anything, but we're gonna keep you in observation just to make sure you're stable, and then we'll send you home. Now let's say that something is a problem. Okay, maybe the swelling isn't going down like they want, or they want you to be able to articulate a little bit and you can't, or but keep in mind, I'm talking about the injury. Now, if you start spiking a fever or stuff like that, maybe it's a complication that they're looking at. However, just make sure if the patient's in observation and they don't get released and they're put in into inpatient status. They said, no, we need to check this. We need to keep you a little bit longer. Okay, so this is when a patient subsequently is admitted, right? Then what do we use for the code? Why is the reason the patient is put on inpatient status? Are they on inpatient status because of the fracture? Are they on inpatient status because of a complication with the fracture, right? So subsequent doesn't mean the same thing as that initial, subsequent, and sequela per se, right? But because that subsequent term is in there, I don't want you to get it confused. Could it be because of the fracture? Absolutely. It could be the reason the patient went from inpatient or observation to inpatient would be because of the fracture, but we're still in initial treatment then, right? It's not, don't confuse being observation to inpatient, subsequent observation to inpatient. That doesn't mean the same thing as the D on the initial or the fracture code. Right. Now that inpatient coding is a little bit different than outpatient coding, of course, but because of that word subsequent, I didn't want you to get that confused, so I wanted to highlight that for you. So I know how confusing some of this verbiage is it can have more than one meaning. And I wanted to bring that to your attention. And likewise, let's say we have a post-op observation, which is really what we would have been talking about versus the previous slide, because the patient would have been in the operating room, they were watching them, so they were in post-op observation, okay, and then they admitted them, right? So what is the diagnosis? It's going to be, and this is a term you need to know, the Uniform Hospital Discharge Data Set and the UHDDS, nobody actually says all that, is what is the reason, what's the principal diagnosis? Why is the patient being admitted? And that's where we go back to, let's say the patient was in observation and all of a sudden they spiked a really high fever and their blood pressure bottomed out. Is that why they're being admitted? Or are they being admitted for the fracture? No, they're being admitted for the blood pressure and the fever. You know, now, why are they having the blood pressure and fever? Well, due to the fracture and the operation, right? So what is the condition that is the reason that they're being admitted? Right? So you have to think about yourself. Think about that. And so this is not dealing with the injury codes and the subsequent care and things. This is a little bit different. And the fracture is usually it's attested to an infection or something, but there could be other injuries involved with the patient. So you got to look at all of that. And so don't get the complication, subsequent, initial, all of that stuff confused when we're talking about a reason for a patient to be admitted versus outpatient. And when you have major injuries like that, you know, like that torsion fracture, that patient is probably actually going to be in the hospital for a little while due to the fracture. Okay. But then if something else happens, right, or then you have to think, okay, was it the injury or is it something else? And that's all in the documentation. Now let's talk about a little bit on rehabilitation, and this is actually where we're going to wrap up. I'm so good at keeping everything to an hour that I keep looking at my watch. Sorry about that. When we're talking about rehabilitation, so a patient is no, well, let's start at the beginning. Okay, so you have a condition and we're getting rehabilitation services for the patient, but the condition's no longer present. Okay, so then it would be an aftercare code that we'd be using. Unless, and this is very important because the unless, and I made this bold. So these are the things that is straight out of the guidelines. The rehabilitation service is being provided following an injury. Okay, so we have our fracture and we have these pins in the knee, and the doctor says, I want you to have rehab because this was a really bad fracture and I want to make sure that that you're able to be mobile and you can walk well after that. Maybe your balance is going to be off because you're going to be favoring that knee, or that you've been off of that leg for so long, we need to do some strength training and build the muscles back up in that leg, right? So if the rehabilitation is due to an injury, then we're going to use the subsequent encounter decode, right? But otherwise, we're going to use aftercare codes because the injury or the condition is no longer present. Okay, so that's very important to distinguish that. Are you going to get a code, a question like this on the CPC? Maybe not, but you might get it on a specialty exam, definitely, right? But these are guidelines that absolutely you could be thrown because you're being tested on the guidelines. Example that I came up with. Oh, no, I think this is an example they gave you in the book. This is not one of mine. So if you have a patient that has degenerative osteoarthritis, okay, they got their hip replaced. This is not an injury, right? They got their hip replaced, and they're going to go for rehab. So this would be an aftercare, Z47.1, aftercare following joint replacement surgery, first listed or principal diagnosis. Okay, that's why the patient's getting rehab. But if the patient has a fracture, okay, post-hip replacement for right fracture of the femur, that's different. That's an injury code, S72.141D. Why are they getting the, they're not in active treatment anymore. That's not a late effect. No, this is, in the ongoing normal healing process, and it is an injury, the reason why they're getting the rehab. Then we're going to go to our injury code, our S code. However, if it was something to do with, like, osteoarthritis is not an injury, it's just a condition, part of a disease process, and we're doing, these two people could be getting the exact same therapy. However, it's two different reasons. Okay, so then you would use the aftercare code, but when the injury is involved, you don't. Real easy way to get tripped up on this. Okay, so make sure you pay attention to the details. And that's it. If you have any questions, thank you for the questions that we did get. What I want you to do is go out and go to the CCO club and put your questions in there. Of course, our club members get questions answered with priority. Maybe you are watching this temporarily because we'll let you, we may stream it on YouTube or Facebook for a little while. Know that if you're interested in being one of our students, you can go to the CCO Club Prime, and you can get all the information about that under the www.cco.us/club. If you're watching us on Facebook and YouTube, don't forget to like and subscribe. We'll keep an eye on questions there, but by all means, jump out and look at the club and become one of our students. We do teaching like this all the time. All right. Thank you, guys. Have a great rest of your day.